What or how do you assess which strength of dextrose to use, or like what do you put in your prolotherapy solutions, and then how do you decide how much to inject in a certain tissue?
Okay, so we don't have great research on comparing different strengths of dextrose in different tissues. And so because of that, we are left with what does the research show us is beneficial, which may or may not be the most beneficial. We don't really know that. So what I mean by that is there's no study comparing intra-articular 10% dextrose versus intra-articular 25% dextrose for us to evaluate which one does better. So that way we're informed on which one to choose between the two. What we do have information on is 25% dextrose intra-articular, and that has shown benefit. There's several trials that have shown positive improvements in clinical symptoms, and there's actually a study that has shown improvement in cartilage resurfacing. And so we know that 25% dextrose works. We don't know if that is the absolute best, but to not deviate away from what we know actually works, we just stick with what we know works. And so, our intra-articular structures, we're generally going to be injecting a higher concentration of dextrose, anywhere between usually 20 to 25%. Although that is not a hard and fast rule, there are exceptions to that rule, meaning we've had situations where we put 5% dextrose inside of a joint because the joint is really inflamed and the person is really inflamed, and we have tried 25% dextrose and they actually got worse. And so we switched and did 5% dextrose and they got better. So, so we take a same approach, but just different concentration there. But generally, if we are trying to get proliferation, we're going to be using 20 to 25% dextrose inside of joints, and then less than 20% dextrose outside of joints. So into our tendons, our ligaments. Usually in my practice, I'm doing 20% for most of those things. In some patients where I think they might be a little sensitive, we'll do a lower concentration, maybe a 12.5, 15%. But most of the time I just do 20% outside the joint and 25% inside the joint. In terms of how much, so some of that comes with you just kind of clinical experience on, one, what I've been taught, and two, watching these injections occur under real time, so under ultrasound guidance, things like that, and watching how fluid spreads and how much displacement of tissue you get with certain injections. So common joints, for example, it is commonly taught in the palpation prolo world, so your hack and hem wall world, to put 10 cc's inside of a knee joint or 10 cc's inside of a shoulder joint. I don't put that much inside of the joint there because I think you can get expansion of the joint capsule, which may not be desirable. So again, if possible, we don't want to stretch out a joint capsule. We just want to put a fluid inside the joint. And so generally for the large joints, so things like the knee, the shoulder, the hip, doing about 5 to 6 cc's in most cases. In some instances, we'll do more. So for shoulder, if someone has a frozen shoulder and we are doing a hydrodilation, so we're actually trying to expand the joint capsule, we might do 20, 30, 40 cc's inside of that joint. Or if a patient they already have knee effusion and we drain off 30 cc's of joint fluid from their knee, then I'm okay putting a little bit more. Maybe I'll put 10 cc's in the knee because I know I'm not going to stretch the joint capsule because it's already been stretched by how much fluid was in there. And so if I can get more platelets in there, more dextrose, then I might take advantage of that. In terms of the periarticular tissues, there's the way that I was originally trained was for each spot that you do, you put 1 cc. That made sense when I was first taught it, right? I was taught by some of the best in the country, people like Harry Adelson, Tina Moore, those people. And so I put 1 cc in everything. But then when I started seeing these injections done under ultrasound guidance, I realized that I didn't like that approach. I don't think it's wrong. I think a better way to do it is to put smaller aliquots in more areas. Now, this is a little different than what other doctors will teach in the conventional prolotherapy space, which is peppering. And that is where you are intentionally trying to basically stab a whole bunch of areas along the enthesis in order to try and cover as much area as possible. I'm kind of in between those two extremes. So you got one extreme where you just put one spot down on your supraspinatus tendon and dump 1 cc of fluid. You got the other side where they're going to go in and they're probably going to pepper that tendon in maybe 10 to 15 different locations, all within a few millimeters of each other, and also be injecting the total of 1 or 2 cc's, whatever it is, at that time. I kind of fall in the middle. So usually I'll put about half cc in each location that I'm injecting into. And again, that's the rule, but there are exceptions to that rule. So smaller ligaments, smaller spaces might be only 0.1 or 0.25 cc's in each area. But from there, then it's redirecting within that enthesis. So again, whether this is the supraspinatus tendon, the ATFL, the iliolumbar ligament, but redirecting within the area that this tendon or ligament is attaching onto the bone and injecting a few different locations. So for example, a supraspinatus, I'll usually do about 4 spots, and each spot is about half cc. ATFL ligament is going to be maybe 2 spots, and each one is probably going to be 1/4 of a cc, just because again, it's a smaller space, smaller ligament, things like that.